Hello guys, today I will discuss about acute management of asthma. Acute asthma, it is divided into moderate, severe and life-threatening depending upon peak expiratory flow rate. If peak expiratory flow rate is between 50 to 75%, then it is moderate, and if it is between 33 to 50%, it is severe, and if it is less than 33%, it is life-threatening. So you have to remember these values by heart. That is between 50 to 75% is moderate, and then after that between 33 to 50% severe, and less than 33% is life-threatening. As far as moderate asthma is concerned, patient is able to speak in moderate asthma, and his heart rate is usually less than 110 beats per minute, when respiratory rate is less than 25 beats per minute. While in severe asthma, patient is unable to speak in one sentence, and heart rate and respiratory rate, they are higher. Heart rate is greater than 110 and respiratory rate is greater than 25. In life-threatening asthma, patient is unable to speak, and actually I have memorized this by C's. Patient cannot speak, then there is central cyanosis, and patient is confused, and then CO2 is normal or it is higher. Normal value of CO2 is between 4 to 6 kilopascals, and usually in asthma there is a type 1 respiratory failure. It means that CO2, it is less than normal value, that is less than 4. But if it becomes normal, it shows impending type 2 respiratory failure, or if it is high, it means patient is in frank type 2 respiratory failure. Other than this, patient can have bradycardia, hypotension and silent chest. Now, how to manage patients of severe and life-threatening asthma? We have to give them supplemental oxygen by 15 liter non-rebreathable mask. We have to keep the level of oxygen in the blood between 94 to 98% if patient is not in type 2 respiratory failure. Then after that, we give nebulization with short-acting beta agonist, that is Ventolin. After that, we can give IV steroids or oral steroid. If patient is having moderate, then we can give oral steroid, that is between 40 to 50 milligram of prednisolone OD. And after that comes the role of ipratropium bromide, then magnesium sulfate, and in certain situation we can also think about giving aminophylline. If patient does not improve, or he is already in severe life-threatening asthma, then we think about mechanical ventilation, that is invasive ventilation. Now here it is in contrast with that of COPD, where in severe COPD we use non-invasive ventilation. In asthma we use mechanical invasive ventilation. So this is a very favorite question in exam, that what is the treatment, ultimate treatment of life-threatening asthma? So that is mechanical invasive ventilation. And another question or another favorite thing which usually occurs in exam is that they give a scenario of asthma and they give ABGs showing normal carbon dioxide or higher carbon dioxide, and then they ask that what should be the management. So of course the management in this case is mechanical ventilation. Then there are criteria of discharge. Patient should be stable on his or her medicines, nebulizer or inhalers for 12 to 24 hours. Number one. Number two, patient should know proper inhaler technique. And number three, his peak expiratory flow rate should be more than 75% of the predicted value. Thank you.